All right, today we're diving into a condition that's both incredibly common and yet so poorly understood, it's often called a hidden disease. We're talking about endometriosis. And trust me, by the end of this, you'll see exactly why it's such a medical enigma. 10%. Just let that number sink in for a second. That's the estimated number of women of reproductive age who are affected by endometriosis all around the world. It's a staggering figure, really. So, to put that into perspective, that's about 1 in every 10 women. Now, you'd think a condition this widespread would be something we'd spot right away, right? But that's where this medical mystery really begins. Which brings us to the central question for this entire explainer. Why is endometriosis so often called a hidden disease, and why on earth does it take so many people years, sometimes close to a decade, to finally get a diagnosis? Okay, so to start cracking this case, we have to know what we're looking for. What exactly is endometriosis? Well, at its core, endometriosis is a condition where tissue that's similar to the lining of the uterus starts growing where it absolutely shouldn't be, like on the ovaries, fallopian tubes, or even on the bowel and bladder. But here's the key. It's not just misplaced tissue. These growths trigger a chronic, painful, inflammatory response. It's really seen more as a full-body systemic disease now, not just a localized problem. And while that 10% number is the overall average, get this. The rates just skyrocket in certain groups. For women who are dealing with infertility, the number jumps to somewhere between 20 and 50%. And for those with chronic pelvic pain, it's as high as 40 to 50%. That shows you there's a really powerful link here. So, the million-dollar question, what causes it? The honest answer is, we still don't know for sure. But scientists have some pretty solid leading theories. So let's investigate these unseen suspects. All right, let's open up the case file and take a look at the top 4 theories that try to explain where endometriosis comes from. Okay, the leading theory, the one you hear about most, is called retrograde menstruation. This is when menstrual blood flows backward, up into the pelvic cavity, instead of out of the body. But here's the real head-scratcher. Over 90% of women experience this phenomenon, yet only about 10% get endometriosis. So that tells us something else has to be going on. It can't be the whole story. Theory number 2 helps explain some of the really strange cases. It suggests that endometrial tissue can actually travel through the bloodstream or the lymphatic system, kind of like a seed floating down a river. This would explain how these growths can end up in really distant places, like the lungs, or even the brain, places that backward flow could never, ever reach. Now, this next one is a really fascinating idea, coalomic metaplasia. This theory proposes that certain cells that line our organs, cells that have been there since we were embryos, can basically transform. They can morph into endometrial-like cells. This could be the explanation for those extremely rare but documented cases of endometriosis in males or even in girls before they've ever had a period. And finally, we have to look at the immune system. You see, in most people, the body's defense system, cells like macrophages and natural killer cells, would act like a cleanup crew and just get rid of any tissue that's in the wrong place. This theory suggests that for people with endometriosis, that cleanup crew is, well, it's not doing its job right. This allows the tissue to set up shop, grow, and cause all that inflammation. So, with so many possible causes, how do doctors actually gather the clues to pin this thing down? Well, this is where the patient's own experience becomes the most critical piece of evidence. We are not talking about bad cramps here, not even close. The classic symptoms are things like severe and worsening period pain, painful intercourse, chronic pelvic pain that never seems to go away, and even painful bowel movements or struggles with fertility. These aren't just minor issues. They are debilitating clues that can completely disrupt someone's quality of life. And here's one of the biggest, most frustrating parts of this whole puzzle. A patient could be surgically diagnosed with stage 1 or minimal disease, but be in absolute agony. Meanwhile, someone else with stage 4 or severe disease might have far fewer symptoms. The stage just doesn't predict the pain. So, the journey to an actual diagnosis usually follows a few key steps. It always starts with the patient's story, their symptoms, and a physical exam. The next step is often imaging, like a special ultrasound, which can spot certain types of cysts. But to get that final, definitive answer, the journey almost always leads to surgery. And that's because the current gold standard for diagnosis is a laparoscopy. This is a surgical procedure where a tiny camera is put into the abdomen, so a surgeon can literally see the implants with their own eyes and maybe take a small sample to confirm. It is, for now, the only way to be 100% sure. Okay, so once the diagnosis is finally confirmed, the focus totally shifts to managing the case. And the treatment is incredibly personal. It really all depends on what the patient's main goals are. You can think of it like a fork in the road. The treatments fall into two big categories. Path number one is all about pain relief for someone who isn't trying to get pregnant at the moment. Path number two is focused on preserving or improving the chances of future fertility. And the answer to that one question changes the entire game plan. So for pain relief, the options range from simple anti-inflammatories to various hormonal treatments. Things like hormonal birth control or progestins work by suppressing the menstrual cycle, which helps shrink the tissue. And then there are more powerful options like GnRH agonists that can create a temporary and reversible medical menopause to basically starve the growths of the estrogen they need to survive. Surgery is, of course, another major tool in the toolbox. Conservative surgery is all about removing the lesions while keeping the reproductive organs intact. Then, for very severe, relentless pain in people who know they're done having children, a hysterectomy can be a final, definitive, though obviously major, step. But what if fertility is the number one goal? That's when the approach shifts. While surgery can sometimes help by cleaning things up, the single most effective treatment for overcoming infertility caused by endometriosis is often in vitro fertilization, or IVF. So after all of this, we're left with a really big, forward-looking question. Given its crazy, wide-ranging effects, its deep ties to the immune system, and its ability to show up almost anywhere in the body, isn't it time we stop thinking about endometriosis as just a gynecological problem? Maybe seeing it for what it is, a systemic disease, is the real key to finally solving this hidden, painful enigma.